Alterations in fluid and acid-base balances. Our body fluids are composed of water and chemicals, electrolytes, which are substances that carry electrical charge when dissolved in a fluid, acids, which release hydrogen into fluid, and bases, which are substances that bind with the hydrogen. The purpose of our body fluids is to regulate fluid volume and to buffer blood to keep its pH neutral. An acid-base imbalance can be life-threatening. These imbalances can be accompanied by fluid and electrolyte imbalances. Regulation of the normal plasma pH is going to be 7.35 to 7.45. We consider that normal. But we have to look at the carbonic acid, the HTCO3, and bicarbonate, or the HCO3. Chemical regulation will be accomplished by adding or removing hydrogen ions, and organ regulation is accomplished by the kidneys regulating bicarbonate levels, while the lungs help regulate the carbonic acid levels. So basically, carbon dioxide is an acid. The different type of imbalance types that we may see would be acidosis, which is an excessive accumulation of acids or excessive loss of bicarbonate in body fluids, or alkalosis, which is excessive accumulation of bases or loss of acid in the body fluids. And a little mnemonic to help you remember that with alkalosis, our pH is going to go up, and with acidosis, it's going to go down. These are the normal values that you need to be familiar with when you're determining acid-base imbalances. It is very important to understand how to determine if we have metabolic or respiratory acidosis or alkalosis. So we're going to look at the pH, the CO2, and the HCO3, or the bicarb. Those are the three that you need to memorize. Metabolic acidosis is caused by increased acids or a decreased amount of bicarbonate. Causes include shock, cardiac arrest, starvation, diabetic ketoacidosis, renal failure, aspirin overdose, loss of intestinal fluid, or wound drainage or diarrhea. These clients are going to have a deep and rapid breathing, or the Kussmaul's breathing, because the client is trying to get rid of acid by blowing off carbon dioxide, which is an acid. They may have nausea, a headache, flushing of the skin, abdominal pain, and weakness. We treat it by eliminating the cause, replacing fluids and electrolytes, and potentially administering IV bicarbonate. So sodium bicarbonate, is an electrolyte or can be considered an antacid. It's going to help buffer that acidity of the acid, so it's going to help decrease acid. We give it with metabolic acidosis. It can cause an irregular heartbeat, so it's very important for us to pay attention to what we're doing when we're administering this medication. We never administer sodium bicarb with other drugs in the same IV line. We always have to dilute it with IV administration. We should never administer it rapidly except in cardiac arrest. And we should always assess for signs of extravasation, which may require the administration of lidocaine or hyaluronidase. Yeah, I'll let you just read that one. Metabolic alkalosis can occur due to the accumulated bicarbonate or decreased amount of hydrogen. It can be caused by an excessive amount of bicarbonate containing drugs, in other words, your antacids, diuretic therapy, vomiting, or gastric suctioning. Excuse me. Consider what is in your stomach. We know that we have hydrochloric acid in the stomach. So if we begin vomiting or we begin suctioning out that fluid, it can upset the acid base balance by removing too much acid. So then it throws us into alkalosis. These clients may experience anorexia, nausea, paresthesias, which are the abnormal sensations in the fingers and the toes and the hands and the feet, confusion, hypertonic reflexes, and decreased respirations. It's very important for us to eliminate the cause. It may require us to administer potassium or sodium chloride. Respiratory acidosis can be acute or chronic, and it's caused by excessive carbonic acid, and it's associated with extreme respiratory insufficiency. So, in other words, if we are unable to make that gas exchange, it will probably be respiratory acidosis. In acute, the causes are going to include our respiratory infections or issues that are going to cause us to breathe faster in order to make that gas exchange, such as a pneumothorax, pulmonary edema, asthma, pneumonia, or those other respiratory infections, atelectasis, drug overdose, or head injuries. So, what's happening in these situations is our body is unable to get rid of the carbon dioxide. So the carbon dioxide is building up. So we're going to breathe faster to try and get rid of it. So if we're not breathing fast enough, that can also cause that buildup of carbon dioxide. We're not blowing it off. Chronic respiratory acidosis can include our obstructive pulmonary diseases, those chronic obstructive pulmonary diseases, COPD, because we know the body cannot get rid of the carbon dioxide. It begins to build up in the body. These clients are going to experience tachycardia, cyanosis, tremors. Again, we have respiratory insufficiency, mental changes, and the chronic symptoms will include that increased respiratory rate, lethargy, and headache. These clients may require mechanical ventilation, airway suctioning, bronchodilators, and or antibiotics. With respiratory alkalosis, this is because we're breathing too fast. So we're getting rid of all of that acid, all of that carbon dioxide. So we're causing a carbonic acid deficit. Causes could include anxiety, fever, an overactive thyroid, aspirin poisoning, or mechanical ventilation. These clients have an increased respiratory rate. They're just breathing way too fast. And when you breathe too fast, a lot of times we get lightheaded because we're pulling in too much oxygen. And that can also cause numbness and tingling of the fingers and toes. So we have those paresthesias. The client may also be sweating or be in a panic state. So what we need to do is have the client rebreathe the air that they have blown out. So we have them breathe into that brown paper bag. That allows the body to breathe in higher levels of carbon dioxide. It may even require sedation to help slow the respirations down. So nursing-wise, we have to report our assessment findings and keep track of those lab values. So which acid-base disturbance would be most characteristic of a narcotic overdose? Remember, with a narcotic overdose, it's going to depress our respiratory system. So our respirations are going to be slowing down. So that means that we're holding on to carbon dioxide. So we have respiratory acidosis. So some of the medications that we may administer with these deficits would be potassium. And we know potassium is an electrolyte. Excuse me. It's going to help improve muscle contraction, transmit nerve impulses, regulate our heartbeats, maintain that acid-base balance, and enzymatic reactions, gastric secretion, and renal function, along with tissue synthesis and carbohydrate metabolism. So basically, we're going to use it to treat hypokalemia. Now, understand that potassium in an oral form can cause abdominal discomfort. We may also see nausea, vomiting, and diarrhea. As long as it's not severe, we would probably continue it, but we may decrease the dose and give it more frequently or do some adjustments there. Of course, we would never administer potassium in the event of severe kidney disease. Potassium is excreted by the kidneys, and if our kidneys are not working, we're not peeing out, then we're holding on to potassium. So we don't want to give more. Adverse effects: diarrhea, nausea, vomiting, GI bleeding, and ulceration. And if we administer potassium too quickly, it can cause cardiac arrest. If you are unaware, potassium is one of the medications that are administered to clients on death row when they are being executed, because high doses of potassium will cause cardiac arrest. To treat overdoses of potassium, we give dextrose and insulin, sodium bicarb, and or calcium gluconate. Then we can also give Kxalate or hemodialysis. If we're giving potassium orally, we need to administer this with food or at least 8 ounces of water to help decrease that gastric upset. If it is a liquid form, we should always dilute it in juice. And we never administer straight potassium IV. We always need to dilute it. If IV potassium is given by bolus, it's going to depress the heart contraction, causes bradycardia and cardiac arrest. So we never, ever, 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 ever give potassium as an IV bolus, except to execute someone on death row. Clients might experience burning along the vein with an IV infusion that has potassium in it. So if the client is able to uh, tolerate the amount of fluid, we need to ask if we can dilute the potassium in a larger volume of IV solution or slow down the administration rate to take care of that burning. So we either dilute it more or slow it down. So Kxalate is, excuse me, also known as sodium polystyrene. This is what we administer in the event of hyperkalemia. It's going to work differently. So ordinarily we excrete potassium in the urine. So if our kidneys are not working, we're not excreting potassium, it's building up. We're developing hyperkalemia. So we have to figure out a different way to get rid of the potassium. So we administer sodium polystyrene. This is going to exchange potassium ions for sodium ions in the intestines. So now we can excrete the potassium ions in the feces. So we need to understand that we have to have a GI system that's working appropriately. We should always assess the client's bowel sounds to make sure that we have adequate function before we give Kxalate. We should never give it if the client is constipated or if they've not had a bowel movement after surgery. And we need to make sure that we don't administer other medications 3 hours before or 3 hours after the administration of this medication. So nursing management is going to be monitoring the labs, and the main lab that we're going to be monitoring is our arterial blood gases. We want to know the pH, the CO2, and the bicarb. Monitor I's and O's and make sure all orders have been implemented, and CPR if necessary. It's important to determine a history of renal, endocrine, especially diabetes mellitus, or respiratory diseases. We need to observe for symptoms of acid-base imbalance. We look at the respirations, their anxiety, their confusion, their dizziness, lightheadedness, seizures, and weight changes. And we also need to know what medications the client is taking. With our physical exam, we look at the client's responsiveness, their vital signs, their weight. We really need to look at the rate, depth, and rhythm of the respirations. We also need to assess their mental status and muscle strength and request ABGs, the arterial blood gases, if acid-base imbalance is suspected. So our diagnostics would include the ABGs, a metabolic panel, and/or a urinalysis. Our biggest priorities with acid-base imbalances are going to be ineffective oxygenation, impaired tissue perfusion, the altered mental status, and altered fluid volume status. Complications of acid-base imbalances. We have respiratory failure, organ failure, shock, seizures, loss of consciousness to the extent of being comatose, and cardiac dysrhythmias. Very important to educate our clients on maintaining hydration and nutrition, to learn appropriate breathing techniques. For example, if they have COPD and they have that chronic respiratory acidosis, doing the pursed-lipped breathing will help them expel more of the carbon dioxide. They should also see the physician if they have continued nausea, vomiting, diarrhea, or respiratory illnesses, because this can lead to acid-base imbalances. And always take medications as prescribed. And now your post-test.